Good afternoon again. So basically, my title for my presentation is Special Consideration in the Management of Heart Failure with Angiotensin Receptor Neprisin Inhibitor in Women. So basically, at the beginning, this is my outline. We'll review the role of ARNI in heart failure with reduced ejection fraction and preserved ejection fraction. Then we'll go over the Paragon trial, which is the main study in heart failure with preserved, and the sub-analysis on women, and compare that with previous trials, and we'll conclude. So we know there are a lot of negative and positive trials over the last 30 years in heart failure, especially heart failure with reduced ejection fraction. But in 2014, one of the positive trials that really changed or shifted the paradigm of heart failure with reduced ejection fraction management was Paradigm trial. And in Paradigm, they used the molecule sacubitril valsartan, which is an angiotensin receptor neprisin inhibitor. We know in heart failure with reduced ejection fraction, there are imbalance between sympathetic and RAS activation from one side and natriuretic peptide activation from the other side. So this molecule ARNI, or angiotensin receptor neprisin inhibitor, it blocks the RAS system that is deleterious, and at the same time it activates the natriuretic peptide system, which is beneficial for the vessels and for the heart. And Paradigm trial, actually, it was compared to enalapril in patients with heart failure and reduced ejection fraction over at least 3 years. And there was significant reduction in the group taking sacubitril valsartan versus enalapril in the primary endpoint, which was reduction in cardiovascular death and first heart failure hospitalization. Not only that, but there was significant 20% risk reduction of sudden cardiac death, reduction of death from any cause, less heart failure hospitalizations, and less days in the intensive care unit. For sudden cardiac death, risk of sudden was less by 20% in the ARNI group compared to enalapril. Not only that, but if we compare the two curves, we can see that they start to separate early on when it comes to reduction of heart failure hospitalization. So within the first 30 days, the curves start to separate and become significant. And this is very important because we need to start these medications early on. So ARNI, on top of ACE and ARBs, it reduced the cardiovascular outcome by an additional 20%. Not only that, but improved the quality of life, because I consider in heart failure, it's not only improving survival and reducing hospitalization, but quality of life is as much important for these patients. And remodeling, one of the main markers of heart failure with reduced ejection fraction is remodeling, or left ventricular remodeling, where the left ventricle become more dilated, the left atrium will become large, and the ejection fraction will be reduced. And from one of the studies, the Evaluate Heart Failure trial, LV and diastolic volume index was significantly reduced at 12 weeks, as well as LV systolic volume index and left atrial volume index in patients taking sacubitril valsartan versus placebo. Not only that, but if we follow up these patients over time, even there is an increase in ejection fraction not only at 6 months, but also it continues at 12 months after follow-up. And this was more evident in patients who were naive to ACE and ARB and presented with de novo heart failure, and they were started on this medication. And if we start this medication early on, during hospitalization or early post-discharge, this not only reduces natriuretic peptide on follow-up, but also improve cardiovascular death and rehospitalization. And this was the basis for having in the guidelines the use of angiotensin receptor neprisin inhibitors in New York Heart Association factor 2 and 3 as Class 1 indication in addition to the other 3 pillars in heart failure with reduced ejection fraction. So they have to be used, and not only that, but also one important thing, they can be used if they are already on ACE or ARB, and if they are still symptomatic, we can shift them to ARNI, and this more important, it will reduce cardiovascular death too. And this brought the second trial, which is the Paragon trial. So we know that in heart failure with preserved ejection fraction, we don't have a lot of evidence on a lot of therapies that really impact the primary endpoint, survival and hospitalization. It was a similar trial to Paradigm, but included as a placebo the other point compared to valsartan instead of placebo in this population or instead of ACE inhibitors. But actually the primary endpoint missed the statistical analysis for reduction of heart failure, hospitalization and cardiovascular death. But actually it was compared to a valsartan, and if they included urgent heart failure visits, then the p-value was significant, with a significant reduction by around 14%. But if we look at heart failure hospitalization per se, also it missed the statistical analysis, while cardiovascular death was not, with p-value was not comparable. But then they looked at the pre-specified endpoints on gender and ejection fraction and others. There were no difference, and there was no P of interaction except with 2, LVEF and gender. Females, they do better with secretory valsartan, and a lower than median ejection fraction, they do better on this molecule. And if we combine Paradigm heart failure and Paragon heart failure with reduced and preserved over the spectrum ejection fraction, we can see that patients, they do better at a lower ejection fraction compared to patients at higher ejection fraction. And actually the cutoff point was 57% LV ejection fraction, where the curve is above 1. Secondary endpoint was New York Heart Association functional class at 8 months was significant in this population, as well as KCCQ, Kansas City questionnaire reflecting quality of life of this patient was also important, and renal composite endpoint. So it has all the secondary endpoint were positive. The second pre-specified endpoint was gender. And we can see if we compare male and females over the LVEF continuum, we can see that males in yellow and blue and females in red, we can see that males, they actually do better at a lower ejection fraction, around 50s, where females, they do better at a higher ejection fraction, reaching up to 60% LVEF. But this has to be secondary to a difference in heart failure between men and women, because women, they have a lower left ventricular mass, a greater contractility, lower apoptosis and cell turnover, smaller coronary vessel caliber, lower blood pressure, higher resting heart rate, and less catecholamine-mediated vasoconstriction. And this could be important, and why it was effective more, knowing that ARNI is applicable or impacts the activation, the RAS activation or the remodeling process. So there are some sex-based differences in heart failure with preserved ejection fraction. This is from CHARM preserved, I preserved, and TOPCAT trials of around 9,000 patients. More than 52% of them were females. We know that women are older in this population. The atrial fibrillation, the presence of coronary artery disease, diabetes are less common in females. Hypertension and obesity are more common in females. Women have a lower self-reported quality of life than males, but men have lower ejection fraction and a higher anti-proBNP in this population. And actually, sudden cardiac death and worsening and all-cause death were lower in women than men in heart failure with preserved ejection fraction. And from this trial, we can see that women, they do much better than men on cardiovascular death or heart failure hospitalization over 4 years, as well as on cumulative cardiovascular death and all-cause death, but not on first heart failure hospitalization. Similarly, they do better, less incidence in sudden cardiac death, less incidence in fatal and non-fatal myocardial infarction. Otherwise, they have no difference compared to men. And this was the nidus to have an analysis of the Paragon trial, sub-analysis of the Paragon trial to compare men and women in this study, in HFpEF study. And they did many primary and secondary endpoint analysis as well as safety analysis. And what is important, I will go over them quickly, that there is difference in age. Females, women have a higher age in this population. There is no difference in duration of heart failure, but ejection fraction was higher in women than men, and this is the distribution of ejection fraction in women and men, where we can see in red that there is a higher ejection fraction in this population compared to men, where they used to have a lower ejection fraction. Second thing, GFR was lower in females, as well as anti-proBNP was lower in females too. There are other baseline characteristics like NIHA class and function and KCCU functional and questionnaire class, which were significant, with a lower reported quality of life in women than men. And when it comes to medical history, less atrial fibrillation in women, less myocardial infarction, less diabetes, and less prior hospitalization. Also, less renal disease, less coronary artery disease, and less PCI and primary and stenting in this population. Less use of mineralocorticoid receptor antagonist, as well as antiplatelets. In addition to some more symptoms in women than men when it comes to the signs and symptoms of heart failure. So this has been shown previously from previous trial too, and from registers on heart failure with preserved ejection fraction, but was the primary endpoint. So on the left side, there are the women, and on the right side, the man. On the total heart failure hospitalization and cardiovascular death as the primary endpoint, we can see that secukinumab valsartan actually did better on the primary endpoint with significant p-value compared to valsartan, while in men, it didn't show any benefit. So on the primary endpoint, women, they do better with secukinumab valsartan, as well as the primary composite endpoint. If they added on top of it urgent heart failure hospitalization, there was significant difference, more in women than in men. When it comes to the components of the primary outcome, heart failure hospitalization, for example, it is more effective in women with secukinumab valsartan than men, as well as when it comes to cardiovascular death, it didn't show any difference between men and women in this population. But if we compare that over the spectrum of ejection fraction, always we see that the line crosses one for the odds ratio in women at a higher ejection fraction, 60 and above, while in men they didn't the curve is less with a lower, they do better with a lower ejection fraction, less than 55, between 45 and 55 in this population. Similarly, for hospital admissions, men and women, they over the LVF, they have the same spectrum. For secondary endpoints, death was the same between men and women, and for heart failure hospitalization or cardiovascular death, more driven by heart failure hospitalization, more towards women benefit than men in this population. And for first heart failure hospitalization alone, all favoring women than men. And when it comes to quality of life and NIHA class, also the change in NIHA class was more favoring in this in this side more men than women, as a paradox in this analysis. But the major key finding points is that women and men with HFpEF have distinct clinical profiles, as we have shown in the baseline characteristics, and compared with valsartan, treatment with secondary valsartan reduced the risk of heart failure hospitalization more in women than in men, as well as different other endpoints. One of them is the proportional improvement in NIHA class with secondary valsartan was similar in women and men, whereas the relative improvement in the quality of life with the KCC questionnaire was less in women than in men. So over half of participants in the Paragon trial were women, so representing one of the largest population of women with HFpEF ever studied. And this difference in the clinical profile between men and women with HFpEF has been shown in different other trials, but this study was not intended to study the difference between women and men, and we cannot really conclude any mechanistic why they do better in women than in men. For a summary, first hospitalization for heart failure or cardiovascular death, women on secondary valsartan, they do better with significant p-value. First hospitalization for heart failure, also women, they do better, while cardiovascular death, there was no difference. One of the important things is that maybe the ejection fraction, what is the normal ejection fraction, differs between men and women. And maybe the normal ejection fraction for women is higher at an ejection fraction around 60%, where in men between 50 and 55%. So this is why we have more patients with a mildly reduced EF in women, and this is why ARNI acts in this remodeling of this population and on the RAS activation more than population above 50%. Also, maybe in this population, men may be undiagnosed with amyloidosis or other infiltrative diseases that they were not effective. Another thing that can explain that from external validation of the TopCat and CHARM that I already alluded before, but in HFpEF trials, there was analysis on the effect of spironolactone across the range of LVEF studied in the TopCat and showed that women appeared to benefit across the whole LVEF, while men only in the lower EF group. And there was similar data that was unpublished in the CHARM preserved trial. This is in the TopCat trial. In blue are men and in red are women. And we can see here there's a flat line favoring spironolactone across all ejection fraction in women, while in men there is intersection and they benefit at a lower than 55 or so of ejection fraction. So this is this analysis with the previous studies, they add on to show that there's some difference between men and women in HFpEF, but not in HFrEF, because analysis in HFrEF didn't show, from the paradigm and other, didn't show any difference. And this may have a clinical implication to prescribe more ARNIs in this female population because it's more effective on the primary and heart failure hospitalization. And this is why it was mentioned in and this was reflected in the ACC newest guidelines as a class 2B indication to have ARNI used in heart failure with mildly reduced and preserved ejection fraction in this population, I think more favoring less than normal, which is mildly reduced, and more in female population. We are waiting further studies in this population of heart failure with preserved ejection fraction with the parallax trial with secondary valsartan 2 till we have other studies. Still, this sub-analysis with previous from the TopCat and CHARM tell us that in heart failure with preserved ejection fraction, there may be some benefit, sex-specific benefit for females and women more than in males, while in reduced ejection fraction, there is no difference. Thank you.